Tell me when.
Start the cages then.
Tell me when I can speak.
Yeah. Okay.
Good evening. I'm Dr. Rajeentheran Suntheralingam. I'm the consultant urologist in KPJ Damansara Specialist Hospital, which is located in Petaling Jaya, Malaysia. We are located in a big city which encloses Klang Valley. Malaysia has a population of 32 million, and Klang Valley is probably a few million population. I'm a urologist and I deal with urological problems. One of the most important urological problems, most common urological problem that we face with actually urinary stones. There's kidney stones, bladder stones, and ureteric stones as well. I hope all of you will find this session interesting. I'll start off with the presentation on what is the kidney stones, how is the prevalence or incidence, how do we manage them. I'll just give you a very brief account of how to manage, and then I'll open up to a Q&A session, and anybody who wants to give a comment or ask a question can go ahead. Okay, I think everybody should be ready now. Okay. Now, very important is in managing urinary stones, we need to understand a few things beforehand. Okay. Now, as you can see here, urinary stones can come with different types of stones and different presentations. We can have different shapes, different sizes, and different composition. The reason is because stones may consist of different minerals that form the stones. Commonly, what we have are calcium stones, uric acid stones, and struite stones, which are actually phosphate stones. Very uncommonly, we have cystine stones. But it's not as simple as that, actually. Although we have calcium stones, which can be a combination of calcium stone with a uric acid component, or uric acid stone with a calcium component, or struite stone. So it's all a mixed stone. You can have many different types of mixed stones, and most of the time in Malaysia we have here is not pure stones, they're all mixed stones. Okay, now how common is stones? The stones are quite common over here, but one has to realize that just because you have a kidney stone, that doesn't mean it's something benign and you should not leave it alone. For example, in this picture you see what is known as a left staghorn stone. Staghorn stone is a very big stone filling up the whole kidney. As you can see here, even though a person does not have any symptoms, the stone can actually damage the kidney significantly. Now, as urologists, we treat a lot of stones in the Asia-Pacific zone. Unlike the urologists overseas in the Western Hemisphere, most often urologists in the Western Hemisphere deal with urological cancers, and the stone incidents are very much lower. But we are in what is known as an endemic stone belt. It is a certain area within the world where the incidence of stones is very high. As you can see, in between the two red lines is exactly where stone incidence and prevalence are very, very high. They are known as the endemic stone belt. These are countries within the Asia Minor, Middle East, North and South India, South China, Southeast Asia, New Guinea, and the surrounding areas. Why is it so? The reason why we have so many incidents here is because of geographical, because of hot weather, and because to some extent it's a different diet. Now, most important to know about stones, and if one needs to prevent stones, they actually need to know why the stones form in the first place. Now, stone forms in the first place is because of concentrated urine. The urine becomes very, very concentrated. Let's say, for example, we have a glass of water. We add in some salt into the water. We can dissolve it. Add some more salt, it becomes concentrated. Add some more salt, it becomes super saturated. That's exactly what happens. Now, stones can have predisposing factors. There are some genetic diseases which can predispose to stones. For example, Dent disease, Bartter syndrome, cystinuria, renal tubular acidosis, but they are very, very uncommon. There are some acquired metabolic defects that can form stones, and these specifically in patients with what is known as hyperuricemia. They are gout patients. So they can also form stone. But the commonest cause is this, dietary and lifestyle factors. Most important is not drinking enough water. Water is required to prevent stones. There's some professions which are very busy, they're always sweating, they don't drink enough water, they are very predisposed to stones. This is a theory by which stones form in a supersaturated urine. Because the urine is very saturated with crystals, and if it becomes very dehydrated, don't drink enough water, it becomes very, very concentrated, very supersaturated. Then you get nucleation, you get crystals starts forming, crystals aggregate with each other, they form a matrix, and finally all the matrix combined together, they form stones. That's the basic and important basic principle of how stone forms. Knowing this, we can prevent stones actually. I'll come to the prevention later. As far as kidney stone management is concerned, or rather kidney stone and ureteric stone, that means urinary stone management is concerned, we have different modalities of treatment. If the stone is very small, then we can leave it alone, see whether it passes out or not. But if the stones are a bit bigger, let's say more than 4 mm or more than 5 mm or 6 mm in diameter, then we need to do something. We've got different modalities of management. The first is ESWL here. It's actually shockwave lithotripsy. Many people wrongly call this as laser. When the patient comes down to meet the urologist, they say, can you please laser my stone? It's actually not laser, it's shockwave. It's sound wave to break the stones. I'll come back to that later. Then we have what is known as retrograde endourological procedures. That means we go through the urine from below, go up into the kidney and break the stones. And we have what is known as PCNL. PCNL is actually reserved for very, very large stones or stack-on stones or any stones more than 2 centimeters, where we puncture into the kidney, make the puncture a bit more dilated to 1 centimeter in diameter. We break the stones and suck out the stones out. I'll come back to that later. Now, this is extracorporeal shockwave lithotripsy, easily known as just shockwave. As you can see here, there's a table where the patient can lie down, and this is the unit, or what's known as a lithotripter, where sound waves can be generated to break the stones. Okay, now this is the basic principle in breaking the stones. The patient lies down on the bed. We give him some analgesics or painkillers. We need to focus the stones, and this unit, this is actually an X-ray unit where we focus the stones. Sometimes we can use an ultrasound to focus the stones, and then we have a shock wave generator here, which then transmits this energy into the kidney, directed to the stone to break the stone into small pieces. So basically, this is what occurs. The beam of shock waves are focused to the kidney stones. Then this energy is transmitted to the kidney stone, breaks it into small pieces. So the principle of ESWL is to facilitate the breaking of the stones to small pieces, by which the patient can pass the stones out in the urine. Basically, we have different types of machines. We have got a Dornier, we have got the EDEB, we have got a different varieties of machines. We have the old generation and new generation lithotripters. In the older generation, in the 1980s, we had what is known as the Dornier HM3, which is the first machine, where the patient has to go into one small swimming pool. They're placed into a swimming pool, they are given general anesthesia, and then shock waves are delivered. It's a bit more of a painful process. Now the newer generation is different. There's no big swimming pool, but a small water containing bubble sort of this thing inside the machine, where the water allows the shock waves to transmit through into the kidney. Basically, the machine consists of a shock wave generator, a table, and either or a C arm and an ultrasound to focus the stones. Now the success rate will depend. Decide okay, which type of individuals are best suited for ESWL or shockwave. There's some patients who are very, very suitable, some patients who are not suitable. Okay. Now, the second modality of treatment for stones, in kidney stones, is what is known as a PCNL, also known as a percutaneous nephrolithotomy. Very long words, very funny name, but very simple. It's just puncturing the kidney. In other words, what we do is we get the patient to lie down on the table, and then we place a needle. After focusing with an X-ray unit, we place a needle, small, very tiny needle, into the kidney, exactly to where the stone will be. Then we pass out a needle or a guide wire into this area. Then we dilate it, continue dilating it, so we have a track. This is the back of the patient lying with the back on top. We have already dilated into the kidney. This is a track, this is a balloon dilator. And then we use a scope to break the stones. We go inside the kidney, break the stones into small pieces, and then remove the stone in pieces. Sometimes we have to do 2 punctures. That means we have to do 1 puncture through here and maybe the upper part of the kidney and 1 part in the lower part of the kidney. Sometimes we need to do 3 punctures, but the punctures are very small. Instead of making a big incision like that to open up the kidney and remove the stone, we just do small punctures and we can remove large stones. What's the advantage? It's only a very small incision, 1 centimeter incision, and you can remove very, very large stones. And the scar is very minimal. Very, very much advantageous from that what we used many decades ago. Many decades ago, we used to make a very large incision, maybe some 15 to 20 centimeters incision, and then open up the kidney, cut open the kidney and remove the stone. But now with only a small incision, you can break the stones and suck it out. The third approach is what's known as a retrograde endourological approach. Very big term, but very simple. We use different types of scopes. These are scopes with very, very small fibers. And we go through from the urinary tract from below. That means the patient will be under anesthesia, either general anesthesia or spinal anesthesia. We go down from below, go up, and likewise here, we go up, right up, then we use a laser to break the stones, and we retrieve the stones using basket. Slowly take it out. This one doesn't need an incision, it's an endoscopic procedure. For endoscopic procedure, we have different accessories for grasping the stone and for many other accessories. This is a scope. Now our flexible scopes can actually bend quite reasonably well. So we can go into the kidney, we can bend it up, right up, and access any other stones in different portions of the kidney. This for the endoscopy procedure. We have got different retrieval devices. This is what's known as stone cone to prevent stones from going up. Then we have here different type of devices to remove the stone. Again, many type of devices to open the stone, remove the stone. These are very, very tiny structures that can go through the ureter up to the kidney. That means it goes up the urinary tract. Okay. Now, after most of the procedures, we need to put what is known as a urethral stent. Now, stents are basically tubes. These are made of polyurethane. Something like a silicone, but not a silicone. It hardly gives an allergic reaction, but some people can find some amount of discomfort. It comes in different varieties. After doing the procedure, we put a stent from the kidney right up to the bladder. Why we put in the stent? Because sometimes during our procedure, it causes a lot of bruising. There's nothing wrong with the bruising. It's okay. It's a normal thing. But when there's bruising, there can be some swelling. So the stent is inserted so that urine can pass through without having any pain. There are some situations when we go up during the endoscopic procedure and it's too tight, or the stone is too stuck, or you have an infection in the urinary tract. When you have an infection, you cannot do the procedures safely, because sometimes the patient can get into sepsis or severe infection. So we usually see whether the patients are capable of standing the infection or not. If they're not capable of standing infection, then we put a stent inside while the stone is still in there. So then the patient can go back, they won't have the stone pain, and the urine can pass through to the stent. Now there's another thing known as antegrade ureteroscopy. Sometimes the stone may be in the ureter, but by going up, it's a bit too tight. So sometimes we go through the kidney itself, same like the PCNL approach earlier. And then we go through that, from above, go down, get the stone and remove the stone. Now the success rate depends on the types of stone. Oh, sorry, yeah, okay. Now success rate depends on the type of stone, the site of stone, and many other factors. Now it depends on whether the stone is in the kidney, the stone is in the ureter, and depends on how big is the stone. I'll give you an example of how this can be done. Let's say you have a very big stone in the kidney. This is known as a Stackhorn stone. Sorry. Okay, this is known as a Stackhorn stone. Now, in a Stackhorn stone, we cannot do shock wave. You know, if we do a shock wave, the stones may break, but it's very big. They break into big pieces. They might fall into the ureter after breaking, and they may get stuck. So for very big stones, more than 2 centimeters or more than 2.5 centimeters, it's better to do a PCNL. So they puncture into the kidney, break the stones, and remove the stones. Those are for big stones. Now, if you have smaller kidney stones, then yes, you can do a shock wave like I explained earlier. Okay, it's a lithotripter, no incision done, straight away doing blasting of the stones. Or in certain people who do not want to do ESWL, or let's say they have got bleeding tendencies, or let's say they are on anticoagulants like warfarin, they have a heart problem, they are on anticoagulants, they cannot stop the anticoagulants, or they cannot stop the antiplatelet or medication that prevents bleeding, then we can do what is known as a retrograde procedure, like what I mentioned earlier. This doesn't need an incision. We go down from the urinary tract, go from below, and then come upwards, break the stone with laser and remove the stones, and then we have to put a stent inside. Okay, what about open stone surgery? This is something that we did many decades ago. For the past 10, 15, 20 years, we rarely do open stone surgery anymore. Why? Because endoscopic surgery is so, we are already quite accomplished in doing endoscopic surgery. Endoscopic surgery is minimally invasive. Complication rates are very low as compared to open stone surgery. But sometimes, when you have a very large stone, when we know the procedures that we do will take a long time, or it cause more complications than we do an open stone surgery. So this is very uncommon nowadays, but there are some indications. When we need to do an open stone surgery, keep the patient to the side, keep under anesthesia, make a big incision over the kidney side, cut open the kidney, remove the stone. That's the stone here. This is the kidney. Okay, clear up all the stones, put in a stent, and then stitch back the kidney. We used to do this commonly 20 years ago. Nowadays, very uncommon. Now, we can remove very large stones as well. Okay, this is a very large stone, 1.2 kilograms when I measured. This one I did it quite some time back, maybe a decade ago. Very large stone. The person presented with a stone in the bladder. Somehow or other had urinary problems, but did not want to see any doctor. Finally came and the stone was so large, had to open up, did an open surgery, and that's how big the stone is. We rarely find this type of stones, but we do see it once in a while. Okay, now coming to near the end of my sessions. Prevention is always better than cure. When we treat stones, after treating the stones, we usually have to advise the patient. How do you prevent stones? Now, we know very well that I mentioned earlier, stones are formed because of supersaturation of the urine. So how do you prevent supersaturation? You put in the urine, make the urine more diluted. So drink a lot of water. So you should drink at least 2.5 to 3 liters of water a day, as long as your medical condition permits it. You're having a heart problem, like heart failure or congestive heart failure or kidney failure or something like that, then of course you cannot take too much of water. Then you have to speak to the urologist, and urologist advise you what to do. But if you're a young person, you're capable of drinking that amount of water, then the best to drink 2.5 to 3 liters water a day. Water is the best medicine to prevent urinary stones or kidney stones. If you want to, you can add citrate. Citrate is all the citrus fruits: orange, lemon, lemonade, lime. Now, citrate has been shown by evidence to prevent aggregation of the crystals. That means prevent the crystals forming together to form the stones. So citrus fruits are the best so far. Thirdly, you have to reduce purine or uric acid containing food. They are same food that people get. People with gout usually end up getting a gouty attack if they eat too much of uric acid food. So these uric acid food includes all the seafood. Fish is okay, but salmon, mackerel, and sardine is high in uric acid. Then red meat is high in uric acid, beef and mutton. Chicken is okay because they are white meat. Nuts and legumes are high in uric acid. Any of the nuts and legumes. Okay. Then, of course, some people talk about reducing oxalates. Oxalates found in coffee, tea, Coca-Cola, and chocolate. So, to some extent, you reduce that amount of salt. And you have to reduce sodium as well, that is salt. But most importantly, if you are a first-time former or first stone former, that means you had the stone for the first time, the diet may not be as important as the water. So, you must drink lots and lots of water to prevent stones. In my practice, I always see stone incidents or prevalence starts rising during fasting months, when people are fasting, because they don't drink much water. So sometimes you can drink a lot of water in the night, but you don't drink water in the day, you can have what is known as intermittent dehydration. So suddenly you'll be dehydrated, the urine gets very concentrated, supersaturated, then a crystal forms. Then you drink water, the crystals already formed already. Then you get dehydrated, the crystal aggregate and become bigger. Then you drink water later, it doesn't make any difference. Then slowly the smaller stone will get bigger, and eventually it forms the big stones. So you must always ensure that you're adequately hydrated all the while. How do you know you are well hydrated? Of course, drink 2.5 to 3 liters water a day. That doesn't mean you have to carry a bottle and drink water every 10 minutes. Then you'll be passing urine every 10 minutes. So maybe every 3-4 hours you drink an adequate amount of water. Make sure you finish up the 2.5 to 3 liters water a day. The second way to know is the color of your urine. The color of urine should not be very dark yellow. It should be very, very mild yellow or clear. And the third is, if you are thirsty, of course, you drink water. If you go to the gym and you sweat more, then you have to drink more water as well. Now, as far as current evidence is concerned, currently there are no known medication to break stones. None of it with evidence base. Herbal and traditional medicines have not been proven to break urinary stones. There are many medicines that have been used in market. Some of them are Rovitanax, cystones, and various products. There's no robust evidence which states that stones can be broken. Because most of the stones are actually calcium based. That means they form a matrix. Once they are calcium based, no matter what we do, we just cannot break the stones. It's very hard stones. No matter what you do, you put in concentrated uric acid also, the stones will not break. So very unlikely anything else can break the stones when consumed by a human being. But there's only one type of stones that can be dissolved. They are pure uric acid stones. Now, in our region, to get pure uric acid stones is very uncommon. Usually the stones are mixed. But if it happens to be a pure uric acid stone, that means pure uric acid stones cannot be seen from a normal X-ray. The pure uric acid stones has what is known as a pKa value of 5.0. In other words, when they are acidic urine, pH of 5, it forms stones. But when you alkalinize the urine, make it into more alkali, and the pH is increased, you can dissolve the stones actually. So you can dissolve uric acid stones by alkalization and by some amount of citrate intake or citrus fruits. But this alkalinization must be at a pH level of 7.0 to 7.5. If the pH values are made more alkali, more than 7.5 to 8.0, then you're in a bad position, because it will predispose to phosphate stones. Now, phosphate stones and brucite stones are very, very hard stones. They are what is known as recalcitrant stones. Once you form phosphate stone as a result of over-alkalinization of the urine, it's very, very difficult to break with shockwave lithotripsy or ESWL. So we do practice alkalization, but only practice alkalization knowing very well that's a pure uric acid stone and not to over-alkalinize the urine. Okay. This may be my final slide. I'm putting this up because many people have the wrong idea of what kidney stones are all about. Now, just because a person does not have symptoms does not mean he does not have kidney stones. Let's say a person has pain for a short time or time being, then they are given painkillers and pain goes off. That does not mean the stone has come out. Sometimes the stone can be there, can be stuck. So the patient may get a very swollen kidney without even knowing that he has a swollen kidney. Very important. So just because pain is absent does not mean the stone has come out. Very, very important. Many people do that. There are many people I meet that say they have been passing out stones for years. They wait for the stone to come out and they pass small stones over years. That's a very dangerous thing to do, because they have been passing stones over the years can mean that once in a while a big stone can get stuck in the ureter and the whole kidney will get very, very swollen and you can get kidney failure. So it's not the right thing to do. If you have, okay, all patients who have passage of stones must be evaluated by urologists. The initial treatment, of course, you can go to a normal clinic and get your painkillers or injections or anything like that. But after that, you need to be properly evaluated. You need to find out exactly where the stones are. You need to find out how big are the stones, and you need to find out what the red flags. Red flags means emergency situations. One red flag is fever. You must never get, when you have a stone and you have fever related to stone, is very, very bad sign, because that can mean you're having an infection. Infection can progress very fast. Very important emergency situation in kidney stones or ureteric stones is an infected obstructed stone. Very, very important. If the urinary tract is infected and you have a block there, the urine has no other passage to come out. So what happens is the urine gets built up, slowly goes into the bloodstream, backflows into the bloodstream, and bacteria will start forming what is known as sepsis or severe infection. So an infected obstructed stone is a urological emergency. It has to be removed immediately. Sometimes we have to put in a stent. Sometimes we have to put in what is known as a nephrostomy tube. Put a tube into the kidney, drain out any infection or any pus, and then only deal with stone. Another emergency situation is when there are both the kidneys are blocked with the stone. That's emergency because you can get kidney failure also. Also, those patients with kidney impairment having a stone is also needs urgent care, with the kidney function can start reducing very, very, very fast. That includes the presence of only one kidney. If you have one kidney, you must be followed up very, very strictly by a urologist, because if you have a predisposition of the stone and the stone blocks that kidney, you go into kidney failure immediately. And the other important thing is about pregnancy. One needs to know that during pregnancy, the calcium in the urine is very, very high. You have what is known as hypercalciuria of pregnancy. So pregnant patients at times can start forming stones as well. It's very challenging because when you got pregnancy, we cannot do a CT scan, we cannot do an X-ray just like that. So it's a bit more challenging. And in pregnancy, we usually can see what is known as a physiological hydronephrosis. Physiological meaning because of the estrogen, the kidney will get a bit swollen. So we will not know whether swelling is due to pregnancy or is due to the stone itself. But if we suspect a stone in pregnancy, then we need to do something about it. Sometimes we can put in a stent, sometimes we have to do a procedure, no other choice. Okay, that's about all for my session today on how does one manage urinary stones, in particular kidney ureteric stones. I'm free for any Q&A or any questions that need to be asked. I will now open up the session for anyone to ask any questions. Okay. I got an inquiry from one Mr. Erwan. He mentioned, I have pain during urination. Is it a kidney stone? Now, it depends on what do you mean by pain during urination. If you have pain in your urinary tract, near where it comes out, that means the urethra, during urination, that does not mean you have kidney stone. That means there's a possibility you may have an infection. Urinary tract infection is very uncommon in males, but more common in females. When you have pain during urination, it means you have dysuria. But the pain must be at the urinary tract, that means the urethra, where you pass urine. Kidney stones, you'll have what is known as loin pain or back pain, which is quite bad. It comes and goes. But you're just having pain during urination, during and not out, before or after, then it's most probably a urinary tract infection or otherwise, or some sort of infection. Okay. Then I got another question from Arshad Daza. Doctor, I have passed small amounts of urine. Do I have stone? Okay, let me put it this way. See, if you have stone on one side of the kidney, if you are a healthy person, you have stone on one side of the kidney or one side of the ureter, it only blocks that ureter. It doesn't block the opposite ureter. In other words, the opposite kidney will start functioning. So your urinary volume may not reduce at all. It does not mean that just because you pass small amounts of stone, of urine, you definitely have stone. It depends on what do you mean by small amount of urine. If you have passed out small amount of urine very frequently, that means that there's something wrong with the bladder. The bladder is becoming too active. It can be due to an infection, or it can be due to a stone in the bladder, which is causing the bladder to contract very often. Sometimes, if you are above age of 50, over age of 60, you have prostate problem. It can cause bladder overactivity, and then you're passing out stones. Passing out urine very often. That is known as frequency of urination. Okay, so frequency of urination, not necessarily due to kidney stone, but sometimes can be due to a ureteric stone very near the bladder, irritating bladder. It can be due to an infection, it can be due to a prostate enlargement, or it can be due to a bladder stone. But if you pass small amounts of urine in volume over 24 hours, let's say only less than 500 ml, then it's a different thing. That means you may be having kidney failure. So it's a question of how often you're passing urine small amounts, which is because of something in the bladder, or you're not manufacturing enough urine. In other words, kidney is not functioning well. That can be kidney failure or kidney impairment. Okay. Another inquiry, is kidney stones common in children? It's not common, generally not common in children, but we do see children having kidney stones as well. If kidney stones happen in children, we have to fully investigate. We have to find out whether they got a genetic predisposition. For example, renal tubular acidosis or Dense disease or Bartter syndrome, or whether they have cystinuria or something like that. They usually have some other metabolic problem, unlike adults, which is due to either high uric acids or not drinking enough water. So we can see children having stones as well. The management is almost the same. We do the same thing. We have to use scopes. We have to do PCNL. We can use ESWL or shock wave. Now, kidney stones with shock wave are quite okay, quite well treated using ESWL for children. But we have to, of course, give under general anesthesia. Okay. Any other questions? Okay. So thank you so much for allocating your time to listen to this presentation on how to manage kidney stone, in particular urinary stones, different modalities, how to prevent it, and so forth. We are always open for any inquiries. If any of you want to inquiry, you can always call us. We are open every day from 8:30 a.m. to 5 p.m. Please feel free to call us, or you can message us for any other inquiries. Thank you for listening to the talk. Sorry, there's a last question. Just sorry, let me get the question. Sorry, there's a last question still. Okay. Okay, as we wait for the message being typed, what else can I see? Can I know about the stones? Okay. You can have stones even in very elderly as well. Now, usually there's a general dictum that states that if you have never formed stones, if you're above age of 60 and your first time you had what is known as a stone colic or pain due to stone, must always be aware. In general, it may not be a stone. If you never had stones before 60 years of age and after 60 years of age, you suddenly have pain, it may not be a stone. It may be many other causes other than a stone. It may be an aortic aneurysm, dissecting anything. That means the large blood vessels in the body is already slowly tearing apart. So dissecting aneurysm is very, very important differential diagnosis. Some people have the ureticolia, they are young ladies, same exact pain. They have blood in the urine also, but they may be ectopic pregnancy. I mean, the pregnancy may not be in the proper place. It may be in the fallopian tubes. They can present exactly the ureticolia. Now, basically, in the Western Hemisphere, if anybody above the age of 60 never had stones before and suddenly present with stones, you must always look very closely. But in the Asian population, especially in the endemic stone belt, even those who are above 60, who have never had stones before, can also form stones actually. So because we are so common here. But outside this endemic stone belt, if anybody above the age of 60 presenting as the first time with pain suggestive of stone, must be very, very aware of other problems other than stones. Okay. Sometimes you can have patients with multiple stones. Multiple stones or recurrent stones. Over and over again, they're having stones. Now, for these patients, we have to do extensive investigations. What we have to do is we have to take some of us do stone analysis. Over here, we don't do that many stone analysis because most of them are mixed stones. And what is in the stone is not the actual metabolic problem in the individual itself. So what we do is we do a 24-hour urine metabolic workout. That means we take the 24-hour urines, we check for the constituents like calcium, uric acid, any cysteine, the magnesium, the phosphate, the sodium levels, and various these things. So we try to find out, and the citrate level. So we try to find out what's the problem in the urine itself. We usually take a blood test to check for calcium and uric acid. But some people may have a normal calcium in the blood, normal uric acid in the blood, but can have very high calcium in the urine, very high uric acid in the urine. So what is in the urine is more important than what's in the blood, because the urine is the end product which causes the stone to form. So for those with multiple stones or recurrent stones, we do a 24-hour metabolic urine workout. We find out if they have low citrate, then we give them citrate. Or they have high calcium, then we try to manage the calcium. Sometimes we can give certain medications like a diuretic to pass out more urine. Sometimes we ask them to drink more water. If it's cysteine, then we have to check for cystinuria and all these others. Okay. We have got a question from Mr. Arshad. Sometimes or some days I drink too much water. What do you think? Okay, as I mentioned earlier, you must only drink 2.5 to 3 liters water a day. If it's medically not contraindicated, that means medically you're well, you can drink 2.5 to 3 liters water a day. If you are very elderly, 80 years old, or you have a heart problem or something like that, then of course you don't overdrink. Now, for a normal individual, you cannot drink more than that. If let's say you drink 5 liters of water a day, if you drink too much, what you're having is you're over drinking. When you over drink, water is supposed to be what is known as a hypotonic solution. It's plain water. When you drink water, you're actually diluting your blood with a lot of water. And what's going to happen is the sodium level, the potassium level in the body will suddenly start reducing. So if you drink too much of water, you'll start having headaches, you start having blurring of the vision, your potassium will be low, you can start having fits or convulsions, your brain may be very swollen, what's known as cerebral edema or brain edema. Water can go into your lungs and clog up your lungs, what's known as pulmonary edema. So too much of water drinking, no, you shouldn't do. Don't drink more than 3 liters of water a day unless you sweat a lot. You're a sportsman, you sweat a lot, you go to the gym, then of course you drink water. So if you are thirsty, you have to drink water. But if you over drink water, no. There are few competitions last time where overseas they used to have water drinking competitions. You must never get into a water drinking competition because if you drink too much of water, you'll have a lot of headaches, you'll have a lot of giddiness, your brains will get swollen and you can even collapse. It can also cost your life. So excessive water drinking is a definite no. Okay, any other Q&A questions or anything? Okay, so we'll close this session. Thank you very much for keeping some of your time listening to this presentation on stones. We in Malaysia are part of the endemic stone belt. The endemic stone belt includes Middle East, Asia zone, Southeast Asia zone, Guinea, New Guinea, and all these regions here. Among our urologists here, we do a lot of stone work because it's quite common. If you have any inquiries, please do send us a message or just phone us up. Thank you very much. Have a nice day. Thank you.